I am very pleased to introduce our Ben Caneen Memorial Plenary Speaker for this year, and that's Professor Chris Baggoley. Chris is the Executive Director of the Medical Services for the Southern Adelaide Local Health Network, following his 5-year appointment as Chief Medical Officer for the Government of Australia. His professional career started when he graduated with a BVSC from the University of Melbourne in 1973. He graduated with a Bachelor of Medicine, Bachelor of Surgery from Flinders University in 1980. Since then, his clinical career has been in emergency medicine, being Director of Emergency Medicine at Flinders Medical Centre and Professor and Director of Emergency Medicine at the Royal Adelaide Hospital. Other roles have included Chief Medical Officer for the South Australian Department of Health, Chief Executive of Australian Commission on Safety and Quality in Healthcare. His time in Chief Medical Officer of Australia coincided with an increase in global concerns concerning health security, particularly the impact of emerging infectious diseases and of antimicrobial resistance. And he had the opportunity to take part in the World Health Organisational responses to all these problems. Please welcome Professor Chris Baggoley, who will be speaking on his perspectives on One Health.
Well, thank you, Sue, and good morning, everyone. This is where I thought I'd perhaps turn off my phone. So just wait a bit, we'll do that. Done. And please, when I finish, if people can remind me, I've left my phone here, my watch, because there's no clock. I've got an hour to entertain you, so this could go anywhere, but let's hope it goes the right way. It's a real pleasure for me to be here and to speak at an AVA conference. I didn't think that would ever happen in my professional career, having worked part-time as a vet through the 1970s, but full-time in medicine since then. So this is an extraordinary honour for me. I too would like to congratulate, though, Robert Johnson for his period as the AVA president for the last 2 years. He's been a zoo vet, and at the Western Plains Zoo, I think, is that right? Taronga. Oh, okay. And Paula, an emergency medicine vet from the Gold Coast, and she and I then have a lot in common with my many years' experience in emergency medicine, and it's just a fantastic appointment. I'd like to acknowledge my friend and colleague Mark Shipp, who's even turned up to listen to me, and he'll regret that, but I hope, Mark, you've got your mobile phone there and you can do your email, so that'll be all right. This is where I gauge the audience and see how far people are away from me, and there's a long way up the back. There are folk who wisely are sitting up the back, and this is where I always regret it, but I ask those at the back, can you hear me? Can you wave if you can hear me? Oh, gosh, you can. I remember doing that once, and there was a bloke in the middle of the audience. It was a longer room than this, longer and narrower, and he looked around and he stood up and he said, well, if they can't hear you, I'd be delighted to join them, is what he said. So, nonetheless, you've just got to go with the flow, don't you? So that's really good. But it's been a real honour to be invited to talk with you today. You're a very long way through the conference, and that any of you are still here is a remarkable thing. I suspect you're sticking around for the dinner tonight. It is at the casino, I understand, so please leave your credit cards behind. Talking for you for an hour it's a long time, but I certainly hope that I can inform and entertain you along the way. Now let's see if I've got the audio visuals right. I do. Of course, first off, I want to pay my respects to Ben Caneen, who is a graduate from Sydney University, like my father-in-law, Don Mackey. Some of you here may know of Don, some of you, the more senior vets amongst you. But Ben, as we all know, died in August 2008 as a result of infection from the Hendra virus. I didn't know Ben, but tributes paid to him after his death described him as a wonderful, bright, optimistic young man who loved his job as an equine specialist. Also infected at the same time was veterinary nurse Natalie, I think it's Bion, and if I've pronounced that incorrectly, I do apologise. In my role as Chief Medical Officer for the Australian Government, I spoke a number of times about zoonoses and of Hendra, and I've used this photo during some of these talks. I know Natalie has had quite a struggle, both physically and emotionally, since her infection, and I do hope she's been able to recover fully. So this lecture enables me to pay my respects to Ben and to Natalie, but also to those who have been affected by the Hendra virus and to the many people in Queensland, New South Wales in particular and elsewhere who have lent their skills, expertise and dedication to fight this disease. The Australian Animal Health Laboratory, that most extraordinary facility, has played a key role in that fight. How many of you have actually been there and been through it? So it is just extraordinary, and it is the main such laboratory of its kind, certainly in the Southern Hemisphere, and only about 4 or 5 in the world. As you know, the security precautions there are meticulous and strict. And you've always got to make sure when you take your clothes off to get into the gear, you've got to go in as you go through, you get to remember to take them all back. And I forgot that the time I went through, so I left a few socks behind, but there you go. I was a member of the AL Strategy Policy Group, which included Mark. Is it still going, Mark, or is it? No, I didn't think it was something I said, but it's moved on. And I think we were both honoured to be involved there. And of course, a facility is only as good as its staff. And here it's scientists, including Deborah Middleton, who played a pivotal role in the development of the Hendra vaccine. Now, just to demonstrate my bona fides, I don't know why I do this to myself. I've got no idea who that bloke is. It seems he was a newly minted graduate in veterinary science from Melbourne Uni. You'll have to take my word that it is me. I wasn't bad with dogs and cats, in theory at least. I think I got my spaying down in under an hour after about 6 years. I wasn't any good at all with horses. I knew the end that bit, and I knew that all 4 feet could create damage, and that was about it. Nonetheless, I got through. I was never that nimble on my feet, particularly, and I still recall this, as life goes on, you forget many things, and some things stick in your brain, and you wonder why. This one did. As I think a 4th or final year veterinary student down there at Melbourne Uni, I was sent out with an artificial vagina to collect semen from a stallion who was being introduced to a mare in season. Now, I suspect they were just having me on. Whatever, the stallion took it very seriously. And as he reared up on his hind legs, he had to just shift his feet a bit. And of course, I had to steer the appropriate member into the appropriate device. And he planted his foot on my foot. And then did his thing. And I certainly came off second best. But I got the specimen, so I was very proud of myself, even if I couldn't walk for a long time. But I lived at Kendall Hall, which didn't have this fancy sign, by the way. I'm not sure too much else has been modified since the 70s. And we lived there with all except our married colleagues for 2 rewarding years. It was just the people that we went through with, the people who became vets were just great people. And I think for my life and career, I was much the better off for having done veterinary science first That was the era when medical students were made to feel like they were gods, and many of them carried on that way since. And I'd hate to think I ever ended up like that. But doing veterinary science made sure that I was never to go that way. In fact, in 2013, we had our 40th reunion, God forbid. I'd been to the first year reunion and none in between. Reunions are fascinating things, I learnt. Most who were there were recognisable, either instantly or after a bit of consideration. But others clearly looked like they were imposters who bore no resemblance to the name card they wore. To this day, I have no idea who they were, but they seemed to be all right. And from this distance in time, I actually want to acknowledge two vets whose positive influence on me I still recall and for whom I will remain ever grateful. They're quite different people, marvellous people. I just want to briefly acknowledge them. The first is Jeff Hazard, who was in small animal and equine practice in Melbourne. I worked with him as a student. He was a marvellous man, patient, still is a marvellous man, a teacher. He failed teaching me anything about horses though, but that's not his fault. But he taught me how a professional should behave. He was ethical, he was concerned for his clients, and I still remember, let's say this is about 1972, 73, the anguish he went through when he figured he just had to raise the consultation fee for a small animal consultation. It went from $2.50 to $3.50. And as I say, caused him great concern. The other thing I remember about him is he never wore a glove when he was doing his rectal exams of pregnant horses. And so he had quite the green arm by the end of the breeding season. By contrast, David Schultz was loud and brash, but also patient, kind and considerate. And Robert and I were talking about Schultzy just as we came walking down here this morning. I worked with him part-time as I was going through the medical course at Flinders Uni. He attracted a clientele of very loyal, knowledgeable, but also thick-skinned, because they had to be dealing with him, dog and cat owners as well as owners of birds and native animals. They avoided me at all costs, the owners of birds and native animals, because they knew I knew nothing about their animals, and they could tell a bluff when they heard it. It was there I retrospectively worked out that the normal temperature of a chook was 38 degrees. Someone stupidly brought in a chook for me to see, took its temperature, 38. What a fever, I said. I'm onto something here, bound to be a virus. I'd imagine I gave it pen strep and cortisone because that's all I knew in those days. Hopefully you've moved on a bit since then. But I also recall successfully diagnosing and treating thiamine deficiency in a dog on clinical grounds, and that still remains my best diagnosis at any stage in any part of my career. Dave and I have a long-standing friendship between our families, and as it's turned out in later years, my wife and I have played a part in the preservation of a rare rock wallaby native to the Tidbinbilla region in Canberra, bringing over very young joeys, taking them by Qantas to the Adelaide Zoo where they were able to be raised. But I did promise to talk about One Health, and I shall. Some definitions here which you can read. Not in the habit of reading slides to people. The one that I though keep in my mind is that between animal and human medicine there is no dividing line, nor should there be. And I think that really is very important. If Mark hadn't done his marvellous thing earlier in the week, I would have, of course, spoken about antimicrobial resistance. Mark and I have done a lot together on that, but I won't go there because I know Mark will have explained that very well. So I'll talk about my experience as Chief Medical Officer with a number of zoonoses and how we prepared for them and responded to them from a human health perspective. But while there are definitions about One Health, I think this comment strikes a real chord with me. It's long on visionary scope and maddeningly short on tangible specifics. And I think that still remains. Is One Health a discipline, a framework, or an ethos, or is it all three? Now, it's not always easy to explain, but I've used this slide taken from the Oakbank races in the Adelaide Hills back in 2004 to explain the basic elements of One Health Australian style, and it worked a treat in Singapore. Now, I want you to survey the scene. Clearly, there's been a fall. Now, I say that, I'm not sure I got a pointer, so you'll have to work it out. But as you can see, there's been a mishap. Now, look at the three elements of One Health. The animal health. Well, the only animal we can see is looking pretty good. Even I could tell that, even though it's a horse, it's standing up. Good sign. You look at the environment. Well, there's a fence, good part of the environment, and there are 4 attendants looking to it. So then you move on to the human health. Oh, I'm not sure if you spotted all 3, but there are 3 jockeys there, lying down, not flash at all. And who's paying them attention? Absolutely no one. Well, I guess they were jockeys, so there's more where they come from. And 2 out of 3 is not bad. So early in my tenure as Chief Medical Officer, I was asked to write an article for the One Health edition of Microbiology Australia, edited by Martin Jago and John McKenzie. and I've got to be clear here, it was my Department of Health colleagues, wrote about the importance of a One Health approach to public health and food security in Australia. Mark Shipp wrote an article focusing on zoonoses in Australia. And in that article, I noted the close connections at government level between health, agriculture and the environment. And you can see the red bits, the human health side of things, green animal health and blue the environment. And health was routinely advised when H5, H7 or H1 was found in our animal stock. And the vigilance for H5N1 influenza in migratory birds was really most reassuring. Now, I won't go through all the committees, but certainly there was a lot of discussion, consultation and cooperation between the groups. Now, you may not realise how historically, certainly animal health and human health were tied up. How many of you have had or still got these books, the Seddon-Ulverston books? I've still got mine. I did throw out some, a couple of years ago. I thought I'm never going to read these. And then the very next day, as is always the way, I was asked something potentially in relation to Babesia and Lyme disease and so on. I thought I should go back and get that. Now, fortunately, I tossed it into a skip for books. So the next day I went back to the recycling depot and jumped in the skip and got it. But the important part of this is that these books, you mightn't realise, were funded by the Commonwealth Department of Health, and truly a One Health endeavour. And one of the first resources I purchased as Chief Medical Officer was this book. Be reassured, and I think Mark will attest to this, I never pretended to recall, because I couldn't, my out-of-date veterinary knowledge, nor to pass myself off as a veterinary scientist. What I did do was recommend to my human health colleagues to liaise with veterinary science as much as they could, and they should, and to appreciate their scientific rigour. Now, this publication came from Veterinarians Without Borders Canada, and their stated mission is to work for and with those in need to foster the health of animals, people and the environment that sustain us. Note that this publication was supported by the Public Health Agency of Canada. Where would you be without the human health folk? I have no idea. And these are the topics that were contained in their compendium, and note that it does include that of Hendra and from Australia. There are a number of slides that show links between the environment, agriculture and infectious diseases. And I've found this the one that is really most helpful to me. And as you can see, it does describe the paths between them, and it starts with the environment, with forest clearance and climate change. It then, with forest clearance, talks about what happens to bats, human contacts with natural hosts, climate change in relation to mosquitoes, crops, livestock, and so on. And by the way, I'm more than happy to have this presentation made available to the delegates of the conference. So you might find some of the slides, one or two, of some value. And this slide highlights the rising frequency of emerging and re-emerging infectious diseases in our world over the last 15 years. I shall talk about the H1N1 influenza pandemic. I'll talk about, and it's not on here, H7N9 influenza in China. I'll talk about the Middle East respiratory syndrome, or MERS, Ebola and Zika. So swine flu, we weren't allowed to call it swine flu for too long because the pig producers were really unhappy with that, just as we weren't allowed to call H5N1 bird flu. So it was H1N1, and it was in 2009. I'm forever grateful that at that stage I was Chief Executive of the Australian Commission on Safety and Quality in Healthcare, so I was able to sit this one out and watch as it unfolded and just marvel at the work it created for people, particularly in health. It caused global fear and it spread globally, and you can see the headlines here. The most serious effects were more in children and pregnant women, because there was a sense that probably older people did have some immunity from exposure to this virus or something like it some long time ago. Population-wise, it wasn't severe, but for pregnant women, a number, it was dreadful, and for children, it was dreadful. Governments were fearful, the media was sensational, and people were scared, particularly early on. But this moment, and this is a very important, you should go back to this slide if you get it, and really marvel at it, because it captured on film. As you know, the swine flu, the H1N1, started in Mexico. And this captured the moment when an infected Mexican pig passed the virus to this typical Mexican boy. And from there on, the world suffered. And nothing was sacred or sacrosanct, even Winnie the Pooh. Now, I'll be in trouble if I read this one out. And I can see the folk at the back can see the screen as well, so that's good. But then, in 2012, a new influenza virus, H7N9, emerged in China in their wet bird markets. Now, China had been the source of SARS, you might remember, the severe acute respiratory syndrome virus. And they were much criticised for their tardiness in letting the world know what had happened, in sharing the virus, and in their activities to stamp it out. This time, with H7N9, they went on the front foot. They alerted the world, they shared the virus, and they invited international experts, including Anne Kelso from the WHO Collaborating Centre for Influenza here in Melbourne, to provide advice. Anne, of course, now is the Chief Executive of the National Health and Medical Research Council. So initial focus in Shanghai, particularly find this in their birds, and these birds, by the way, were not unwell. They didn't show symptoms, unlike when they get H5N1 and they are unwell. But Shanghai closed their live bird markets and they slaughtered their birds. And they limited the outbreak of the initial virus attack to just 6 people in that vast city. It tends to become active in their winter, which of course is the time of the Chinese New Year, at a time of markedly increased tourist activity to China and especially from Australia. So you might wonder then how it is that we can protect our country from this virus. Well, you must be reassured, and this will be a recurring theme, because we're very prepared at our air and seaports, because we have a pamphlet. And we keep them stocked. And if you wave the pamphlet in front of your nose and mouth, it wards off the virus. So, now, Australia had an Australian Health Management Plan for pandemic influenza in the expectation of an H5N1 pandemic, which of course could still come. There are a number of phases in this plan. The first was to prevent its arrival in Australia, to delay it once it arrived, and then to contain it. Now, a number of serious people, and I regret to say I was there because I was South Australia's Chief Medical Officer at the time, we sat down and we put that plan together and we believed in it. Now, who on earth could believe you could prevent a virus travelling in people from getting into this country? I just don't know what we were thinking. I mean, it's a virus, for God's sake. But after the H1N1, all countries, I think, reviewed and revised their flu plan, as did we. And we gave up, and I had a significant role with this. We gave up pretending that we could prevent a virus coming into this country. There was elements of preparedness and response, standby, action, and then stand down. We knew we'd have to use the first few weeks in particular of a pandemic to really understand what this virus was doing in our country. The attack rate, the morbidity rate, the mortality rate, and have a close follow-up of all contacts, after which you'd learn as much as you could and you just focus on containing virus. I am a member of the World Health Organization Pandemic Influenza Planning Framework Advisory Group, and I'm still on it, which meets twice a year to help prepare the world, particularly low and middle income countries, to combat the next pandemic. And I can tell you this work is taken extraordinarily seriously at that level. Now, I've come to the conclusion that bats are the source of all evil. I did so early in the piece. As we know, they were the definite source of Hendra, and they were the probable source of H7N9 passing to chickens and other birds, which sort of indirectly then brings me on to MERS, or the Middle East Respiratory Syndrome. As you can see, it's a coronavirus. It's a close relative of SARS. Of course, the common cold is a coronavirus, and having just had one of those, the common cold does rank right up there with SARS and MERS. At least it did in me. MERS hasn't reached Australia yet, but has affected 26 countries. How many of you have heard of MERS? Gee, if I did that in the medical audience, I wouldn't get nearly that response. Well done, you. It has a 30% mortality rate, and especially worse for the elderly and with comorbidities, and for which there is no specific treatment. The prime suspects for its spread to humans were camels. And research has been done on camels, and this, of course, is where the OIE, the World Organization for Animal Health, has played a very serious role. And of course, we know Mark is president-elect of that organisation and continues his fine work in that area. There was antibody evidence in this study of Egyptian dromedary camels, high levels of high titers to MERS in those camels. Much to the consternation of some government departments in Australia, our own camels were tested. I never did quite work out, Mark, why folk got excited, but I think they were worried if it came back positive, then we'd all be in trouble. I think Mark and I would have lost our jobs. But all tests were negative. So it was a good thing to have done and reassuring. But behind every infected camel, that was the one with the antibodies, behind every infected camel is a bat. I mean, I do not know how bats carry so many deadly diseases and look so damn healthy, but they do. And I'm sure you could tell me that. Now, this shows a slide from 2015 of the spread of MERS. And you can see the spreads in green. The red dots signify the magnitude of the infection in the relevant countries. The biggest red dot is in the Kingdom of Saudi Arabia, where the main focus of this disease remains. No country outside the Middle East had more than 5 cases until South Korea. The WHO set up an emergency committee to advise its Director General, Margaret Chan, as to whether the outbreak represented a public health emergency of international concern. I chaired that committee. It had 17 members who only met by teleconference. And by the end of the teleconference, it was early morning for me, and at the start of the teleconference, of course, it was early morning for those in the Americas. A public health emergency of international concern was never declared, even after 13 meetings, because mainly it didn't need international assistance to contain it. But it did go close when it spread to South Korea, where eventually they had 184 cases. There were several reasons for the spread in South Korea. The first was that people at that stage were looking for Ebola. MERS had slipped their mind a bit. The second was that it spreads, and the greatest bulk of the spread, even in the Middle East, has been in hospitals, in crowded emergency departments in particular. So when sick people get together, they're not well, and they share the MERS virus, then it can cause a significant attack rate. But in the community, these people at home, the attack rate was about 5%. So it's just a bit of a conundrum, that one. And there's also the practice in South Korea that if you don't like the treatment you're getting in the hospital you're in, you get up, you take yourself and your relatives take you to another hospital. It could even be 100 kilometres away. You go to the best hospital. And as it turned out, the best hospital, so-called the Samsung Medical Centre, then became the site of the greatest number of infections, and they had to close it down for a period of time. It was brought under control by strict home quarantine of suspects and their contacts in a way that South Korea could do. I just couldn't see working in a country like Australia, where I imagine strict home quarantine would be taken as a suggestion. Maybe you should stay at home for a bit in between getting out every now and then. One remarkable feature of this outbreak has been that not one case has arisen from the annual Hajj pilgrimage undertaken by millions in the world, and often they're unwell. Often people know that they should do the pilgrimage once in their lifetime, and if you're unwell, now we should do it. Now, there's been at least 4 or maybe 5 Hajj since this outbreak started in the Kingdom of Saudi Arabia, and there's not one case that's gone internationally. Of course, all pilgrims are known. They can't just turn up. So in Australia, we knew who was going. We made contact with the Muslim communities and their designated travel agents, and we reached every pilgrim before and after their trip to Mecca. And more good news, we've got thousands of pamphlets at the border. And we even gave them to people that came back from the Hajj, so we felt very reassured. But the whole approach to MERS has been a One Health approach on a global scale with WHO, OIE and the FAO, particularly in the Middle East, combining to better understand this disease and how to control it. Now, while many people haven't heard of MERS, and when they do, they don't know what to make of it, everyone has heard of Ebola, and the vast majority are terrified of it. Thanks in large part to Hollywood. As you know, there are 2 films devoted to Ebola, Outbreak and Contagion. I couldn't bring myself to watch either of them while I was the chief medical officer. It would just depress me, I thought. But on late night television, just in the last few months, I caught Outbreak. Now, it had bad signs. And as they say, try to remain calm. Indeed, well, you couldn't watching that. And if you thought that's what Ebola was about, then you would be terrified. And particularly when the solution in this film was to eradicate Ebola in a key area, was going to be the bomb that particular township into oblivion. No wonder people got scared. Apparently, Contagion has got this right. Nothing spreads like fear. And it has better science. As I say, I haven't watched it yet. So let's get to the science. And this One Health approach, and from the Centres of Disease Control. As you can see, bats, the source of all evil there, right there in the middle, and the bats being the reservoir host for the Ebola virus. Carrying the virus, they can transmit it to other animals, and you have animal-to-animal transmission, as shown here, particularly apes, monkeys, and antelopes, but as well as to humans. And from time to time, you can have a spillover event when an animal or a human becomes infected through contact with the reservoir host, and that can occur through hunting or preparing the animal's meat for eating. And then you have human-to-human transmission. Now, before the outbreak in West Africa, 10 minutes. No, you've all got longer, haven't we? Yes, please. 10 minutes, it's only 10 past. I better speed up. There have been 26 outbreaks of Ebola in Africa. None reached the level and scale that you find here and we found in West Africa, which had never had an outbreak. It's where social customs, particularly at death, magnify the spread of the disease. And this was the reality, the awful reality. And the world was scared. The WHO formed another emergency committee, and I was a member of this one, and in no time declared the Ebola outbreak in West Africa a public health emergency of international concern. But when Thomas Duncan went from Liberia to Dallas, became unwell, went to the Presbyterian Hospital Emergency Department, was sent home to a crowded apartment where he developed vomiting and diarrhoea. He returned to the hospital and died in critical care and infected 2 nurses. The American citizenry went into a panic, fearing it would be overrun by Ebola. And the world was now very fearful. Even though almost all experts and professionals around the world were giving sound, evidence-based and sensible advice. And this demonstrating the difference between, say, Ebola and measles and the similarity, but the profoundly different effects that measles had on the world. That there were cases outside West Africa was bad news initially, but then good news because it didn't spread in America and public health advice and measures worked. There was some debate even in Australia as to whether Ebola spread by airborne compared with droplet means, with the vast weight of opinion, was that it only spread by droplet, but not everyone was convinced. Nevertheless, healthcare workers demanded additional precautions in their personal protective equipment. As you can see on the left, you've got a healthcare worker in the American system dressed ready for the Ebola, but after further experience and concern, you can see the difference that was changed in relation to that. There was great concern in all governments across the world, and the Australian government shared in that concern. Now, I can't refer to meetings of the National Security Committee of Cabinet, so I can't say I was called there 6 times. I was asked by the Prime Minister if I could prevent a case of Ebola coming to Australia. And I said, no, I couldn't say that. But I was confident we could stop the spread. And Health had the lead on this, and Health also liaised within our region, World Health Organization, and with the states and territories, of course, you had to mount the response. We did agree on PPE to be worn, admittedly close to CDC guidelines, but informed after quite some significant debate by our infectious diseases physicians and infection prevention and control nurses. The engine room of the health response to any major incident, be it an infection, a pandemic, or a natural disaster, is the National Incident Room in the Department of Health in Canberra, where there's normally just a core group of 4 to 5 people, but who can be augmented by over 100 well-trained, if you like, reservists who have other jobs within the Department of Health, and they get involved to coordinate a national response. And our epidemiologists are caught at this work. It was very political at times, political about Australia's not helping in West Africa until the December of the key year, political about our preparedness to support our region, but not political about our preparedness to support and ourselves. The global panic eased considerably when the spread didn't occur in the US, and when those who had been in close contact with Thomas Duncan in his apartment didn't become infected, when the nurses who were infected they recovered and didn't spread it to anyone else. The good news, again, in our preparedness, we almost had thermal scanners at our airports. We avoided that. We had entry cards instead. And of course, we had pamphlets, hundreds and thousands of them, and clearly they worked. Now, throughout all of this, one moment will remain for me. 43 countries have come together to promote global health security, supported by the WHO, but led by the US, Finland and Indonesia. I attended this meeting at that time representing Australia in Washington in the White House. The highlight was the address to the delegates by President Obama, who spoke for an hour on 2 topics, antimicrobial resistance and Ebola. He came over as the Public Health Commander-in-Chief, inspired everyone there. This was just a few weeks before Thomas Duncan, the fallout from which was said to have cost him those midterm elections because he had been responsible, they thought, for letting Ebola into the country. I did try the podium on for size, but I never got past the primaries. Now, Zika came out of the blue. It seemed it came out of the blue and gained global attention and concern, particularly with its impact on Brazil and the Olympics being staged there. But Zika was first identified 70 years earlier, when the virus, a flavivirus, was found in a rhesus monkey in the Zika forest of Uganda. It's mosquito-borne, Aedes aegypti, which of course we have in northern Queensland. And it's there, though, that the Australian work on Wolbachia bacterium, introducing that to infect that mosquito, has reduced its ability to become infected with dengue and, it seems, the Zika virus, both, of course, being flaviviruses. The devastating consequence for the developing fetus, a more recent clinical development, of course, was of greater concern. So Australia did have cases of Zika, but I didn't hear if any resulted in fetal malformation. But now, in closing, it's important, and those of you who ever have to give a lecture when you've got someone in front of you wanting to talk to you, about half an hour before you finish, you say, "Now, in closing." Does that make sense? So you reassure them. Don't worry about holding up the signs. We're almost done. On to more mundane matters. What harm could there be in a petting zoo? Well, a lot at the Ekka in 2013, where 19 people at least caught the Shiga toxin-producing E. coli from calves, sheep and or goats at the animal nursery there. Those of you from Adelaide will recall the Shiga toxin, E. coli and hemolytic uremic syndrome that followed in the 90s, which was a devastating circumstance for a number of people. And what harm could there be in puppies? Well, plenty it seems. It seems that there was an outbreak of Campylobacter in some nursing homes in the ACT. I'm not sure if any of you recall that. And a 4-month-old puppy copped the blame. And there's a lot of Campylobacter around. How they shitted home to that puppy, I'm not sure. But the recommendation was that puppies be excluded from nursing homes until they're 12 months of old, when their carriage rate of Campylobacter was much less. And of course, cartoonists had a field day. Now, Mark, you have heard this story, but I couldn't resist this one at the AVA conference. And this is the final story. Truly. So I want to finish on a story that, as Mark knows, I've told before, but hopefully not to you, or at least to most of you. It links veterinary teaching, veterinary ethics, veterinary practice, and how all of this has had a profound effect on the development of safety and quality practice in human health. So how One Health is that? So this is the story of Archibald. Now, Archibald, as you can see, was a Pomeranian who was brought in to be, castrated. Now, as you know, very much more than anybody out there, as we all know, Pomeranians are very small dogs. And they're easily excited. And you know they're excited when they show you their teeth, which in my experience was all the time. Now, this is too scary, so I'll just move on. Now, Archibald was the first case in the surgical list in a suburban Melbourne veterinary practice. I will not name it. And I was a student in my final year. Now, as you all know, Pomeranians don't need much anaesthetic, even less when they're excited. So inserting a needle into one of their veins constitutes excitement for a Pomeranian. So one shot of anaesthetic from the vet, and Archibald was dead, like immediately. Cactus, like a dead parrot, you know, the Monty Python sketch. Snuffed it. You've got the picture. So the vet immediately asked for the contact number of the owner and went to the phone. I was mightily impressed. Was this to be the famous open disclosure that veterinary surgeons were famous for? Now, you'll know about open disclosure. It's telling the relevant person, here the owner, what happened, explain the steps to remedy the situation for the injured or affected patient, and take steps to ensure others don't suffer the same fate. So it's all about openness. And I was wondering then, I wonder if they use open disclosure in human medicine. Anyway, I listened very intently because I knew this was going to be a major learning situation for me. The discussion went like this. Mrs. Grimwade, not a real name, understand, vet here. I've just given Archibald his anaesthetic, and he's had a bit of a reaction. Probably a severe allergy. We've got him in intensive care. Of course, he's really flat out, rigor mortis setting in, and he's on the table out the back. So cases came and went, no problems, and the vet goes to the phone between cases. Very impressive. Mrs. Grimwade, he's vet here. Archibald's putting up a brave fight. We're doing all we can. Now, this is a true story, by the way. Much better since, I'm sure. So more cases come and go. No problems, more phone calls. Then the last call. Mrs. Grimwade, vet again. I'm a bit worried there might be brain damage. What's that? Put him down? A wise idea. And by the way, there'll be no intensive care fee. So what ethics? What disclosure? Mrs. Grimwade had been told what happened, why it happened, and the consequence for the patient. Now, My only anaesthetic disaster came several years later. I was a fully fledged vet. Come to think of it, there was a budgerigar, but okay, there was a budgie. But I had a rabbit brought in for a shave. The fur was clumped and matted. How the family let the rabbit get in that state, I don't know, but I held my tongue. Simple procedure, needed an anaesthetic though. Now, rabbits don't need much anaesthetic, even less when they're excited. And inserting a needle into an ear vein of a rabbit constitutes excitement for a rabbit. One shot and it was dead. Cactus, you get the picture. So my Pomeranian experience, that's why your student flooded back. Where was the phone? Then reality set in. You see, the rabbit was being held throughout by its owner. Who was a vet nurse for her father, who was a veterinary surgeon. And she knew a dead rabbit when she saw one. It got worse. The owner was my wife. And it was our children's pet. So I got a bit of open disclosure. I had to explain the allergic reaction to the children. We didn't divorce. In fact, we've been married 40 years. But it was the end of an otherwise promising career in veterinary anaesthesia. But I could take open disclosure to human medicine, and it's a task which I have now resumed. All done. Thank you very much.
Thank you very much for a great talk. We've got time just for a few questions. Has anybody got any questions they'd like to ask? About dead rabbits or dead Pomeranians or... No questions?
So you made me rush from...
There's one up the back. There you go.
Thanks, Professor. That was wonderful.
Down here. Sorry.
In a lot of the talk, you mentioned about the how bats play a key role in the reservation of a lot of these viruses, and it can be perceptually interpreted by the general public that bats are bad. If the campaign or whatever was put that wipe out the bats, then my understanding would mosquitoes and so forth would populate, and then there's another problem. Would you elaborate on your views of that sort of concept?
Yeah, look, thank you, and thanks for raising that issue. Of course, I talk of bats in the way I do. You can hardly make a joke about a bat. But this is where it is extraordinarily important that the veterinary profession, in particular, points out the role of the bat in our environment. And as you know, there was a period of time in Queensland where the government of the day was determined to wipe out bats. Now, how on earth they would do that, I have no idea. If attempts were made, they would become more stressed and shed more viruses. So that's where, and again, particularly in a One Health circumstance, the role of the bat in the environment needs to be well explained, and the veterinary profession is best to do that. Was there one up the back?
Chris, do you believe that the medical profession are well enough trained in zoonoses?
Yes, no. It's not the case. And again, that's where the animal health people do need to add. I mean, clearly now medical courses, 4 years, flat out, and there's so much to learn. As you find, of course, in your veterinary studies, there will be some people that learn a lot, and there is interest in One Health, and particularly from the infectious diseases specialists, and they have strong voices in animal role of zoonoses and other infections. But I think, and Mark, you'd agree that we've not found a great understanding of zoonoses or of microbiology or of parasitology. Those issues are just not the source of great focus. And I couldn't see who asked the question, which is why I'm looking around up that end. Thank you.
Hi, thanks. Can you explain to me why Australia doesn't have rabies? We're up here.
Yeah, very good. Sorry, can you
back up.
Because you can
back
almost...
up that way up there? Sorry.
Yeah, you can
What's the
almost-
question again? Sorry.
Rabies. Can
Yes.
you explain to me why Australia doesn't have rabies? My brain has a problem with this because Timor you can almost walk across on low tide and it's there and it's in Indonesia. I'm just not convinced that maybe we have a sylvatic cycle.
Well, as you know, we do have the Lyssa virus up there in Queensland, again transmitted by bats, which I think has killed 3 people, one about a 7-year-old, Mark, about 3 or 4 years ago, which is a very close relative of the rabies virus. But you're right, it's there in Bali. And we have hundreds of thousands, I think something like 800,000 tourist visits to Bali from Australia each year. Our quarantine laws make the big difference. I mean, the fact that we're an island doesn't stop us from having other viruses, of course, come in carried by humans. But our quarantine laws do stop, it seems, and have effectively stopped this virus from entering Australia through animals, which of course is the only way it can be. We have a number of people who need the rabies vaccine, having been bitten, having gone to Bali, and they come back to Australia and are protected that way. So I think it's down to yourselves and the effectiveness of our quarantine that has caused that happy circumstance, and long may it remain.
Thank you, but you can't quarantine bats.
Yes?
So that's my question.
Yes, well, again, you'll know better than I do whether bats can get as far from those islands into Australia. Clearly, the evidence to date is that they haven't, although they do have the Lyssa virus. So, but we haven't demonstrated here ever, I don't think. Mark, is that correct?
So bats are moving between Australia and Papua New Guinea, but not carrying rabies, just carrying Lyssa.
Just carrying the... So maybe it's a bit of luck yet. Thank you. Good question.
Thank you very much. I'm afraid we're going to have to end it now because we've got another session coming, and I'd like you to thank Chris for a wonderful talk.